Okay, I think we can start.
Yes. Good morning, everyone. Today I'll be presenting on topic total anomalous pulmonary venous connection. We'll be covering this topic in further subheadings, including the introduction, embryology, history, types of the TAPVC, its clinical features, investigations, and surgical management. Introduction. Total anomalous pulmonary venous connection is a cardiac malformation in which there is no direct connection between any pulmonary vein and the left atrium. Rather, all the pulmonary veins connect to the right atrium or one of its tributaries. A concomitant right-to-left shunt, commonly via an interatrial communication in the form of patent foramen ovale or atrial septal defect, is present in essentially all patients with TAPVC and is necessary for survival after birth. The physiological consequence of anomalous pulmonary venous connection is usually anomalous pulmonary venous drainage. It is possible, however, to have normal pulmonary venous connections with abnormal drainage in case of common atrium and malposition of the septum primum. Pulmonary veins in these anomalies connect normally to the left atrium. Either complete absence of the interatrial septum or abnormal attachment of the septum primum can lead to anomalous drainage into the morphological right atrium. When some or all of the pulmonary veins drains anomalously into the right atrium or its tributaries without being abnormally connected, the terms partial or total anomalous pulmonary venous drainage with normal pulmonary venous connections are used. So, the terms pulmonary venous connections and pulmonary venous drainage should not be used synonymously. Coming to the embryology, successful connection between the pulmonary venous system and the left atrium is a result of three distinct processes that involves the formation of primitive lung bud and the primitive left atrium. Primitive lung bud originates as outpouchings from the trachea on day 26-27 of gestation. A plexus of vessels, the splanchnic vessels, develops around the lung buds and allows the drainage into the anterior cardinal veins and the umbilicovitelline veins. At 27 to 28 days of the gestation, solitary pulmonary vein originates from the forming left atrium towards the dorsal venous plexus through the dorsal mesocardium. The image which is showing the formation of the splanchnic plexus, the connection between the right common cardinal, left common cardinal, and umbilicovitelline veins. At day 30 to 48, the solitary vein bridging between the left atrium and the lung retract backwards towards the posterior wall of the left atrium, a process made by complete involution of the pulmonary to systemic venous connections. Failure of all the pulmonary veins to divide from the splanchnic venous system and possibly concomitant leftward displacement of the developing atrial septum is hypothesized to be primary defect in the embryological development. History. TAPVC was first described by Wilson in 1798. In 1951, Muller attempted the first surgical repair by anastomosing the common pulmonary venous sinus to the LA appendage using a closed technique. In 1956, Lewis et al. Reported successful open repair using moderate hypothermia and inflow occlusion in a 5-year-old child. In 1956, Kirkland reported successful repair of the TAPVC using HL-Well technique and later CPB. Currently, repair is accomplished on CPB using bicaval cannulation and moderate hypothermia or using deep hypothermic circulatory arrest. The types of the TAPVC according to the site of connection to the systemic venous system. The most common type is supracardiac, which constitutes around 45 to 55%. The common vein connects to the structures above the heart, including the right SVC, the zygous vein, the left SVC, or the innominate vein. The image which is showing the supracardiac TAPVC connection to the innominate vein, to the common vertical vein, which is draining into the innominate vein to the right SVC. The second common type is cardiac type, which constitutes around 15 to 20%. The pulmonary venous confluence drains into the coronary sinus or sometimes into the RA. In some patients, the pulmonary veins converge into a short vertical vein before draining into the coronary sinus. These patients are more susceptible to late obstruction. Infracardiac or infradiaphragmatic type, which constitutes around 15 to 25%. Obstruction is the most common in this group, in this subset of the TAPVC. The pulmonary venous confluence drains via descending vertical vein to either the portal vein, ductus venosus, gastric vein, right and left hepatic veins, or directly to the IVC. The fourth type, which constitutes around 5 to 10%, is the mixed anatomy. The most common of mixed type consists of bilateral and asymmetrical connections. The left upper lobe of the lung drains into the left vertical vein, and the remainder of both lungs drains into the coronary sinus. The second most common is bilateral and symmetrical connection, in which the right lung drains into the coronary sinus, and the left both pulmonary veins drains into the vertical vein. The individual right and left pulmonary veins usually converge to form a common pulmonary venous sinus, which in turn connects to the systemic venous system, usually posterior to the pericardium. Long axis is oriented transversely. In case of infracardiac drainage, the right and the left pulmonary veins slope downward to converge into a vertical sinus in an arrangement of Y, T, or tree shape. Really, there are two vertical veins that are not confluent until below the diaphragm. A common pulmonary venous sinus may be absent in some cases with cardiac or lymph connections. On the basis of obstruction, there are two types, obstructive and the non-obstructive TAPVC. Obstruction occurs in nearly all patients with infracardiac and with connections to the azygous vein. It can also be seen in the supracardiac and the cardiac TAPVC, but more common in the infracardiac. Less common in patients with the cardiac connection, 65% with the patients with presenting to the superior vena cava, 20% with connection to the coronary sinus. Rarely, stenosis of the individual pulmonary veins at or close to their connections to the common pulmonary venous sinus. The second common obstruction which occurs is at the level of the interatrial communication at the level of the PFO or an atrial septal defect. The causes of obstructive TAPVC can be intrinsic causes and the extrinsic causes. The intrinsic causes includes the absent common pulmonary venous sinus, the long length of comparatively narrow connecting vein, stenosis of the vertical vein connecting to the pulmonary venous sinus to the systemic venous system. Sometimes the left vertical vein passes posterior rather than anterior to the left pulmonary artery and is compressed between it and the left main bronchus. This constitutes as the extrinsic cause of the obstructive TAPVC. The vertical vein may be narrowed at its junction with the portal vein or ductus venosus or where it penetrates the diaphragm. Obstruction can occur at the level of portal sinusitis and rarely associated with coronary atrium. This is an image showing the supracardiac TAPVC with an individual pulmonary veins formed horizontal confluence behind the LA. The left vertical vein connects to the left innominate vein, which constitutes into the right SVC. The vertical vein is sandwiched between the left main stem bronchus posteriorly and the left pulmonary artery anteriorly. This is another image which is showing the infracardiac type of the TAPVC. The ductus venosus is atretic at two locations, between the vertical vein and the suprahepatic segment of the IVC, and between the vertical vein and the confluence of the umbilical and the portal veins. The associated lesions which are associated with TAPVC, nearly always an ASD and PFO is present. Atrial communication is usually of adequate size and non-obstructive. There is frequently no pressure gradient between the two atria even when the defect is small. Right atrium is enlarged and thick wall. Left atrial appendage is normal in size. Left atrium is abnormally small, possibly by the absence of the pulmonary vein component. In patients with the TAPVC to the RA, the posterior attachment of the atrial septum is shifted towards the left, so the septum lies nearer to the sagittal than the usual coronal plane. Left ventricle is usually normal in size, but the LV cavity is usually small due to leftward deviation of the septum, which is caused by the RV pressure volume overload. Right ventricle varies in size depending on the magnitude of the pulmonary blood flow, the presence or absence of the pulmonary venous stenosis and obstruction, and the point at which the anomalous pulmonary veins connect. When connection was infracardiac, Howard and Reid found that the RV was neither hypertrophied nor dilated. When venous connection was supradiaphragmatic, the septum in the RV were hypertrophied and RV was dilated. Structural changes are usually found in the lungs of even the youngest infants dying with malformation. Increased pulmonary artery muscularity and medial indentation thickening are often intimal proliferation. PDA is present in about 15% of the cases, and in nearly all infants presenting in the first few weeks of life with obstruction. VSDs can occur occasionally. One third of the patients have other major anomalies, which include TOF, DORV, interrupted aortic arch, truncus arteriosus, tricuspid atresia, hypoplastic left heart syndrome, pulmonary atresia, multiple VSDs, and coarctation of the aorta. The combination of TAPVC with other major cardiac anomalies is especially likely to occur when there is atrial isomerism. Esophageal varices can occur in obstructive TAPVC and likely caused by obstructive veins. Hypoplasia of a small pulmonary artery has recently been identified in obstructive TAPVC. The syndromic associations includes the Holter-Rann syndrome, Klippel-Feil syndrome, and Gatti syndrome. Coming to the clinical features, the signs and symptoms of the TAPVC are variable and depending on the underlying hemodynamics, whether the patient is having obstructive or non-obstructive TAPVC. When obstruction is present, symptoms occurs shortly after birth. Patient will present with tachypnea, feeding difficulties, and infants will develop failure to thrive, repeated respiratory infections, sometimes requiring mechanical ventilation. Cardiorespiratory failure will develop by 6 months of the age. Later, patient will have clubbing, hepatomegaly, and edema as features of the failure. Cyanosis may be clinically inapparent except in the presence of the cardiac failure and secondary pulmonary vascular changes. Severe metabolic acidosis develops when obstruction is severe, rapidly leading to myocardial necrosis. During the first 2 weeks of the life, tachypnea due to TAPVC may be impossible to distinguish clinically from other conditions, which includes the meconium aspiration and myocarditis. Respiratory distress syndrome has classical radiological features, and patient will have intercostal and sternal injury. Coming to the physical examination, the arterial pulse will be small because LV stroke volume is reduced. Pulmonary hypertension will be there with restrictive interatrial communication results in the large A wave. Precordial bulge with hyperactive RV impulse is present. Cardiac impulse is maximal at the xiphoid process on the lower left sternal border. Prominent RV heave is a typical finding on palpation. Auscultatory findings. Characteristic quadruple rhythm is seen in cases of TAPVC, in which S1 is loud and distinct and is often followed by systolic ejection click. S2 is widely fixed and split because of the large AST. S3 is almost always present and heard best in the apex. S4 is frequently heard in older patients. Grade 2 by 6 soft to medium ejection systolic murmur is heard over xiphoid in the lower left sternal border. Diastolic tricuspid flow murmur at the lower left sternal border occurs frequently because of the large AST. When the anomalous pulmonary venous connection is to the left innominate vein, a venous hum at the left or right base may be heard. This murmur is not louder during diastole and is not altered by change in position or pressure on the neck veins. In infants with pulmonary venous obstruction, auscultatory signs are determined by pulmonary hypertension rather than increased pulmonary blood flow. Coming to the investigation, first is ECG. PR interval will be prolonged. Atrial fibrillation can occur in older patients with ostium secundum ASD. Peak right atrial P waves are there, right axis deviation, inverted T waves, and deep left precordial S waves corresponding to the signs of the RVH also, and right bundle branch block. Coming to the chest X-ray, the lung fields will reflect the increased pulmonary blood flow. RA and RV will be enlarged, PA will be prominent. A figure of 8 or snowman appearance is seen, especially in patients with the TAPVC to the left innominate vein in case of supracardiac TAPVC. This diagnostic sign is usually not present in the first few months of the life, but is seen in older children and adults, usually after 6 months of the age. This is the X-ray showing the figure of 8 appearance, which is formed by the anomalous vertical vein on the left innominate vein, and on the right side by the SVC, right SVC. When the anomalous connection is to the right SVC, dilation of this structure results in prominence at the upper right cardiac border. Coming to the echo, the goals of echocardiac examination are to establish the diagnosis, image and determine the size of the individual pulmonary vein, ascertain that all four major pulmonary veins joins the venous plexus confluence, and no additional pulmonary vein treats separately. Determine the size of pulmonary venous confluence and its relation to the LA. Image the course of pulmonary venous channel and its connection with systemic vein and its relation to neighboring structures. To determine if there is obstruction to the pulmonary venous flow, evaluate the interatrial communication for obstruction, and to exclude the additional structural cardiac anomalies. In echo, we'll find a large RV with a compressed left ventricle, a large RA and a small LA with deviation of the atrial septum to the left and dilated PAs. The interatrial communication is usually present with the right to left shunt. PFO occurs in 70% of the cases and ostium secundum ASD in 30% of the cases. A large common pulmonary venous sinus may be seen posterior to the LA in parasternal long axis view. M mode may show abnormal motion of the interventricular septum, a sign of RV volume overload. Doppler study shows an increased velocity in the PA and increased flow velocity or continuous flow at the site of the pulmonary venous region, and findings are suggestive of pulmonary arterial hypertension. The most common site of correction is the left vertical vein with subsequent drainage to the dilated left innominate and the right SVC. These abnormal pathways can be imaged in the suprasternal short axis view. Color flow mapping and Doppler ultrasound are helpful in defining the direction of flow in the left SVC. The most common site of entry into the coronary sinus occurring in 15% of the cases. Dilated coronary sinus best imaged in parasternal long axis view, subcostal and apical four-chamber view. This is the apical four-chamber view, which is showing the coronary side, dilated coronary sinus. In the infracardiac type, a dilated vein, descending vertical vein into the abdominal cavity through the diaphragm is seen. It is seen best in subcostal and supraesternal short axis view. In a transverse plane, the descending aorta lies to the left and posteriorly, the IVC and to the right and anteriorly. Annulus pulmonary venous channel is in intermediate position. The descending annulus vein may be missed if it is compressed by a congested liver. Flow in the IVC is nearly continuous facing and towards the heart. Flow in the common pulmonary vein is characteristic of the venous flow pattern, except the direction is away from the heart towards the abdomen. In the mixed type, multiple windows must be used to image the connection at least of four individual pulmonary veins. In the most common mixed type, the left upper lobe usually drains to the left SVC and the remaining pulmonary veins drains into the coronary sinus. Cardiac catheterization is helpful when echo findings are ambiguous or other complex defects are present. A classic finding in cardiac catheterization associated with TAPVC is identical oxygen saturation in all chambers of the heart. As a result of the mixing of oxygenated pulmonary venous blood and deoxygenated systemic venous blood, helpful in defining the anatomy of pulmonary vein stenosis, which may develop after the repair. Balloon atrial septostomy may be helpful in hemodynamic stabilization before surgical repair in patients with obstructive TAPVC. These procedures may temporarily stabilize critically ill patient, allowing time to recover from multi-organ dysfunction. Another view is that it should never be used in critically ill patient as it delays the operation and exacerbates the myocardial failure and pulmonary edema. Uh, MRI and CT scan are not necessary in the initial evaluation of the newborns and infants with the TAPVC because echocardiography is accurate. In older patients and elective circumstances, these provide a superior alternative. This is the coronal section of the CT, which is showing the left upper pulmonary vein, left lower pulmonary vein, and the right lower pulmonary vein, which is draining into the vertical vein, showing the infracardiac type of the TAPVC. All venous blood returns to the coming to the physiology. All venous blood returns to the right atrium. Some form of communication between the right and left side is necessary, which occurs in the form of PFO and ASD. During fetal life, the pulmonary blood flow is small, and the combined systemic and pulmonary venous return is only minimally increased. As after birth, as PVR gradually decreases and demand for systemic blood flow increases, with the growth of infant, massive pulmonary overcirculation ensues. Increased right atrial pressure results in pulmonary congestion and impaired oxygenation. The distribution of the mixed venous blood depends on the relative compliance of the atria and the ventricles and the relative resistance imposed by the pulmonary and the systemic arterial circuits. Sometimes there is streaming of systemic venous return into the RA, directing IVC blood through the PFO to the mitral wall and the SVC blood through the tricuspid wall. Thus, in intracardiac TPVC, systemic arterial saturation is typically higher than pulmonary artery saturation. QP by QS in such patients is determined primarily by the pulmonary blood flow. Since PVR is inversely related to the pulmonary blood flow, saturation is a rough guide to the patient's operability. Coming to the natural history of PVC is relatively uncommon, constitutes around 1.5 to 3% of the total congenital heart diseases, generally have a poor prognosis. Only about 50% survive beyond 3 months and about 20% beyond first year of the life. That occurs in first few weeks and months of the life in most neonates because of the low cardiac output syndrome. Infants who survive first few weeks of the life usually have cardiomegaly, large pulmonary blood flow with mild cyanosis. Most have some degree of PAH. Their clinical syndrome includes tachypnea, recurrent episodes of severe pulmonary congestion, failure to thrive, fluid retention, and hepatomegaly. Those who survive the first year of life without surgical treatment usually have a large ASD. They tend to be hemodynamically stable for 10 to 20 years with little change in the PVR, PA pressures, blood flow, and saturations. In the second effect, pulmonary vascular obstructive disease develops leading to the increasing cyanosis and Eisenmenger's complex. In a study by Hazelrigg and colleagues, 180 autopsy cases, the median survival was 2 months, shortest being 1 day, longest being 49 years. 90% of the deaths occurs in first year of the life. Obstruction of the pulmonary venous pathway reduced median survival from 2.5 months in the non-obstructive group to 3 weeks in the obstructive group. So patients with supracardiac and cardiac median survival was 2.5 to 3 months, and in patients with infracardiac connection had a worse prognosis with median survival of 3 weeks. Only three patients had mixed connections, two died at 5 months of the age, one died at 3.3 months of the age. Presence of an ASD was associated with increased
Those
survival,
slides,
particularly
the slides have disappeared.
presence of an ASD was associated with increased survival, particularly when the connection was not infracardiac. Indications of the operation diagnosis is the indication. For less than 6 months of the babies, investigation must be undertaken promptly in any neonate or infant, no matter how young, who develop signs and symptoms which are suggestive of TAPVC. Procrastination leads to death in babies with obstructive TAPVC. Ideal time for surgical intervention is during the first few days to weeks, a few weeks of the life, frequently in the first month, usually before 6 months of the age. For 6 to 12 months of the babies, operation should be taken promptly because of the risk of the operation is low. Even infants who appear to be doing well are at risk of dying before the age of 1 year. Rarely individuals survive into childhood or early adult life with TAPVC and are first seen for surgical correction consideration at that time. Operation is advisable if severe pulmonary vascular disease has not developed. In TAPVC, the degree of cyanosis and mean PA pressures relative to systemic pressure is not helpful because of the common mixing chamber and the shunt is not being at the systemic level. Pulmonary vascular resistance is calculated in suspected patients at preoperative cardiac catheterization. Using fixed principles, the patient responds to 100% oxygen and to the inhaled NO is determined. If the pulmonary vascular resistance is less than 8 units per meter square, using these maneuvers, operation is undertaken. And if resistance is more than 8, a chronic pulmonary vasodilator therapies, both pre and post-operative is employed, can be considered in attempt to increase the operability. Coming to the techniques of the surgery, repair of the supracardiac TAPVC. Surgical repair of the supracardiac TAPVC is accomplished by median sternotomy with two venous cannulae, the IVC, SVC, and an aortic cannula. Immediately after the initiation of the cardiopulmonary bypass, the ductus arteriosus is ligated and divided, the aorta is cross-clamped, and cardiac arrest is induced with antegrade cold blood cardiobridging solution. The heart is retracted cephalad and to the right, exposing the left posterior pericardial area. This maneuver is enhanced by absent connection between the pulmonary veins and the atrium. The vertical communicating vein is ligated near its connection with the innominate vein or SVC to avoid tethering of the vein ostia near the site of the planned anastomosis. When severe preoperative obstruction is present, leaving the vertical vein patent may contribute to the relief of the postoperative pulmonary vein hypertension, although significant residual left to right shunt may require re-intervention later. A longitudinal incision is made in the confluence in the posterior wall of the left atrium. Because collateral pulmonary flow can be extensive, cardiopulmonary bypass flow rates may need to be decreased temporarily to facilitate the visualization and the placement of the incision. Small cardiotomy suction cannulas can then be placed in the pulmonary venous confluence and the perfusion flow rates are restored. Through a left atriotomy, the interatrial communication is closed primarily or with a patch of autologous pericardium. Alternatively, the venous confluence behind the left atrium is assessed from the right following a leftward retraction of the heart. A transverse incision is conducted along the right atrium inferiorly across the Waterston's grove and through the posterior wall of the left atrium. The confluence is exposed and incised longitudinally between the pulmonary vein ostia. The anastomosis is then performed starting at the leftward corner of the incision and moving rightward. The interatrial defect is closed with a patch of autologous pericardium and the repair is completed. This approach offers excellent visualization of the confluence without significant distortion while avoiding the rightward retraction of the heart. Also, this technique permits the patch enlargement of the left atrium, which is usually small. The vertical vein may provide a useful vent for the non-compliant left ventricle in the early post-operative period. One approach is to measure the LA pressure after discontinuation of the bypass. The vertical vein is then snared. If the LA pressure does not rise and the systemic pressure does not fall, the vertical vein is ligated, otherwise it is left open. The later situation is most often the case in patients with infradiaphragmatic TAPVR. By ligating the ascending vertical vein, care must be taken not to injure the left funicular, which lies on the anterolateral surface of the vein. Ligature must be close to the innominate vein to avoid the misdirection of the left upper pulmonary vein to the innominate vein. The PFO or ASD can be closed either from left side or through a small incision on the right atrium. Following completion of the operation, fine pressure catheters into the RA, LA, RV, PA are placed for appropriate post-operative monitoring. Coming to the repair of the cardiac type of the TPVC, when the communicating vein is connected to the coronary sinus, access is obtained through right atriotomy. The portion of the septum between the ostium of coronary sinus and the fossa ovalis is incised and the basin valve is removed. The opening of connecting vein is usually seen in the mid portion of the coronary sinus. The coronary sinus is then unroofed towards the left atrium. In cases in which the confluence is connected to the coronary sinus by an obstructed communication, this is also incised back to the confluence via the coronary sinus to provide an unobstructed drainage to the unobstructed drainage of the pulmonary return. This is the arrow which indicates the path of blood flow through the coronary sinus to the RA before repair, and after the repair, blood flow from the coronary sinus is to the LA above the mitral wall through the unroofed coronary sinus. The repair of the infracardiac TAPVC, the vertical vein is typically extrapericardial and descends into the abdominal cavity via the esophageal hiatus. The confluence is often aligned vertically in a Y shape. Exposure can be obtained from a left approach, retracting the heart anteriorly and to the right. Alternatively, access can be gained through a biatrial incision from the right side. Once access to the confluence is obtained, the vertical vein can be ligated. As noted, some authors recommend leaving the vertical vein intact to allow decompression of the small non-compliant left atrium into the systemic venous system, thereby diminishing the post-operative risk of pulmonary venous hypertension. Once the confluence has been opened with a vertical Y-shaped incision, the repair is carried out. The supradiaphragmatic portion of the vertical vein can then be used to augment the anastomosis to the left atrium after its division. Infants usually presents with critical state and its severely obstructive pulmonary venous return in the case of infracardiac TAPVC. The configuration of the pulmonary veins can be T, Y, or tree-like, with the largest and the longest parts of the confluence oriented vertically. A primary repair of the infracardiac TAPVC by sutureless technique. This is the image which is showing the descending vertical vein and the four pulmonary veins. Incision is carried out at the level of the left atrium and the vertical vein is ligated and divided. Edges of the left atrial wall are sutured to the posterior pericardium using a suture line that is removed from the incised pulmonary venous confluence. In the mixed type of the TAPVC, the commonest pattern is three veins, which is to a posterior confluence, and one separate, which is connecting to the systemic venous system. Repair often involves an anastomosis between the left atrium and the confluence as described previously, and the implantation of the fourth vein if possible. Single unobstructed pulmonary vein can be left in situ to avoid post-operative restenosis. Emoto et al. Have demonstrated a small residual left-to-right shunt from a single residual anomalous pulmonary vein in continuity with the systemic veins did not result in significant hemodynamic compromise. When only one pulmonary vein drains anomalously, it may be left uncorrected without significant physiological consequences. In cases of isolated return of one pulmonary vein high into the SVC, the repair might compromise SVC, sinus node, or sinus node artery and is best avoided. Coming Coming to the post-operative care, the relationship between the LA and RA pressures are very important. LA pressures may be considerably higher than RA after repair. A high LA filling pressure may trigger pulmonary arteriolar vasoconstriction. The LA pressure trace after operation is then characterized by steep wide descent. Continuous monitoring of the PA pressure for at least 48 hours after repair is essential, as PA pressure and PVR may remain high. Diuretics are usually required for several days post-operative period to minimize the pulmonary edema. Acidosis must be vigorously treated. PaCO2 should be kept below 25 to 30 mmHg by hyperventilation. Fentanyl should be continued for at least 36 hours post-operatively. Use of inhaled NO may be particularly helpful in the case of development of the PA crisis. The phrenic nerve may be damaged by dissection of the ascending common vein, traction, or by eye slush. Early diagnosis using echo and early diaphragmatic plaque shortens the postoperative recovery. Pulmonary venous obstruction occurs in around 10 to 20% of the patient, usually because of the anatomy.
There are no slides.
Now, sir?
Complication, yeah.
Yes. Pulmonary venous obstruction occurs in around 10 to 20% of the patients, usually because of anastomotic obstruction or pulmonary venous stenosis. Usually presents within first few months. Rarely it may manifest 1 or more years later. Early presentation and post-operative pulmonary hypertension have affected the outcome. Pulmonary venous stenosis is more often related to the neointimal hyperplasia. Record et al. Reported the incidence of 9% of progressive pulmonary venous obstruction in a series of 178 patients. Small-sized pulmonary veins at the time of presentation may predict the progression of the pulmonary venous obstruction later and survival. Results. Incremental risk factors for early death includes the earlier age of the presentation, single ventricle intracardiac morphology, infracardiac and the mixed type of the TAPVC, pulmonary venous obstruction, poor preoperative physiological state, and low weight at the operation. Risk factor for late death is usually recurrent or persistent pulmonary venous obstruction. In older patient, a mild or moderate increase in PVR increases the risk of operation, and severe elevation renders them inoperable. In up to 10% of the patient, structures appears to develop at the anastomosis usually within few months of the repair. Reoperations are required for severe anastomotic stenosis in the pulmonary vein stenosis. A study from Great Ormond Street Hospital showed that only 1/3 of the reoperation occurred within first 6 months of the initial repair. Pulmonary vein stenosis is usually lethal. In 1996, Ricard, Gatt and colleagues described the sutureless repair of the technique using an in situ autologous pericardium for recurrent pulmonary vein stenosis following initial TAPVC repair. A follow-up every 6 to 12 months is recommended. The suspicion of pulmonary vein stenosis requires cardiac catheterization angiography. Activity restriction is usually unnecessary unless pulmonary venous obstruction occurs. Endocarditis prophylaxis is usually not needed unless an obstruction is present. So I have taken references from the Pavlov's, Mavrodis, Coughlin, and Sebastian surgery of the chest. Thank you.
Thank you. You sound unwell, but still you did this presentation. Thank you for that. How many cases of TAPVC have you seen?
Sir, 3 cases I have seen, sir.
Okay, what were they? Supracardiac, intracardiac?
Supracardiac and cardiac, sir.
Okay, so at least you have an idea, because otherwise most of it would have been theoretic. What I suggest is, when you take a topic, at least you should have seen at least 1 or 2 cases before you talk about the surgery. So when you read before and then see a case and then present a seminar, it would make much more sense. Now, the TAPVC, one of the important thing is to know the presentation. So TAPVC is one of the causes of cyanosis at birth, isn't it?
Yes.
So what is the differential diagnosis of a patient with cyanosis at birth?
Sir, TGA, truncus arteriosus, pulmonary atresia.
Yeah.
First,
TAPVC.
Transposition, first thing.
Transposition of great arteries. Yes, sir.
She said TGA, truncus, TAPVC, and tricuspid atresia.
Yes, sir. And
Right.
pulmonary artery. Yes.
Yeah. 4 T's and 2 A's. Yeah.
Yes, sir.
That is important. So most of the time when you see a cyanotic child at birth, then you have the clinical features and the X-ray finding. X-ray finding, of course, the snowman appearance comes much later. The most important diagnosis by echo. So you rightly said the supracardiac, the infracardiac type, and the infracardiac type. And when you talked about the surgical technique, you go back to that infracardiac type repair. You said something called sutureless repair, right? I didn't understand that. What was that?
So can you see that slide?
No, it's blank. So can you explain this? I didn't follow this. How can this be sutureless? I don't know. Jairaj sir, you'll be able to tell us, sir.
I don't understand that.
Anyway, so this is one thing that the diagrams should go along with the site that you're talking about. You should understand what exactly this is. So just check with some of your consultants. Again, we don't have an expert opinion from the practicing surgeons in these classes. And then two things that you did not tell us is one is NH experience itself, as we always ask you. And secondly, what do you see the post-operative pulmonary venous congestion or constriction of the pulmonary venous connection is one of the commonest complications of the surgery. So what is done for that in the follow-up period or immediate post-op or follow-up period? So these things you should know, okay?
Yes.
Apart from along with the results, because you said in the natural history, only a very small percentage survive beyond 1 year if there is no surgery done. And then subsequently, the commonest, almost 20% incidence of pulmonary venous obstruction that occurs in the post-operative period. So how is that tackled? I am not too sure about that, and maybe Jairaj sir will be able to tell us a little more on that. Sir.
The incidence usually there's a 1%. You said up to 3%. Usually the statistic is about 0.7 to 1.5%. So roughly you say the incidence of TAPVC is about 1%. And you said the natural history depends entirely on whether it's obstructed type or non-obstructed type. The obstructed type, hardly any patient survives more than 2 months. Whereas the non-obstructed type, about 2/3 to 75% of them die in the first year of life. And once that's over, they present like an ASD with recurrent respiratory infections and failure to thrive. Then the other thing, when you classify, the most often the old surgeons expect you to say the Darling classification. That's one. Type 1 supracardiac, type 2 intracardiac, type 2, 3 infracardiac, and type 4 mixed. And the incidence also, you said about 50% supracardiac and about 20 to 25% is a cardiac, And that in that about 15% will be in the coronary sinus and the less directly into the
Into the
right atrium. And the infracardiac, you mentioned most of the cause of obstruction because of the it goes through the esophageal hiatus into the abdomen that may join the portal vein, the ductus of Quia, uh, even the
That is what
hepatic vein, or even in the IVC. Very often obstruction will be in the sinusoids of the liver. So that is commonly. Then, so the obstructed one needs immediate surgery. The other one, you said about 6 months, is the time of surgery. The other thing, the approach actually, you put that cardiac type, where you put a diagram of cardiac, which I don't agree with that. No, not this.
No, not this. The cardiac type. This is
Yeah,
supracardiac.
cardiac type.
Yeah.
Cardiac type, there is a diagram.
yes, sir. 1 second. So only these two diagrams are there.
No, there's another diagram. That one. Just before.
This one, sir.
No. That diagram, we are lifting the, this one. Is it the operation for a cardiac type? If you
No,
look
sir.
at, if you look at the Kirkland's Boy's book, this is the classical approach for a supracardiac type where the right atrium is not opened. You dissect out the right atrium, below that the left atrium, below that the common pulmonary venous chamber. So you retract the heart to the left and open the left atrium above and open the common pulmonary venous chamber. And that, of course, it is retracted little more to almost up to the left atrial appendage, and then open both and make this is for the classical. If you see Kirkland's book, this is the picture they have given for the classical supracardiac type of Tapvc.
Yes.
Then there are three methods. Then the other thing, the classical intracardiac type, you make incision in the right atrium, arising also in a supracardiac type. There's another trans-atrial approach in which you open the right atrium from the atrial appendage up to the inferior vena cava, take state sutures, then you see the ASD, you enlarge the ASD vertically and take sutures. Then you see the posterior wall of the left atrium. You make a transverse incision in the posterior wall of the left atrium. Take different colored stay sutures because you'll be confused at the end which are the layers to be sutured. So behind the left atrium, you see the common pulmonary venous chamber, and you make a similar incision as in this picture, at transverse incision, and then you start making anastomosis between the common pulmonary venous chamber and the left atrium posterior wall. Then you close the area with a patch, then you close the right atrium. This is the classical approach for a. And if it's a coronary sinus, you make an incision so that the coronary sinus wall is cut off, and then the whole thing drains in the left atrium, and you put a large patch for an ASD, including the coronary sinus, draining the coronary sinus in the left side, left atrium. That's usually done. And the other thing is you put the infracardiac one, infracardiac picture. The usual technique is actually you, after you going on bypass and the taping, all those things, then cardioplegia. Even before that, you open the right pleura very much and you rotate the heart to the right side so that you can see nicely all the uh, pulmonary veins, the left atrium, all those things can be nicely seen. Then, then you make a large incision and anastomose the vertical way. In that, one technique you said is that you can disconnect the vertical vein at the diaphragm level and use that also for making the anastomosis left atrium. But the anastomosis is larger. That's all. The, you said the complications, and the complications are maybe because your anastomosis is large, immediate complications, or pulmonary vein stenosis is common in about 9% of the cases, which is probably one of the most difficult things to treat, The pulmonary vein mouth stenosis cannot be treated well. Then the other thing is that you didn't mention that one of the postoperative complications is a pulmonary hypertensive crisis. You mentioned that, they
Yes.
hyperventilate to get a PCO2 of 30 or 35 and then nitric oxide. So that is a pulmonary hypertensive crisis.
Yes, sir.
Because most of these patients have pulmonary hypertension.
Yes.
Especially those cases where it's obstruction, even when there's no obstruction, because of the large flow, they develop pulmonary hypertension. The other thing we always say that cardiac utilization, oxygen saturation is equal in all the chambers. But there's an exception sometimes. They said in a supracardiac type, there's something called streaming of the blood. Streaming of the blood means the the IVC blood in the fetus comes up and it goes through the canal of the sinus into the left atrium. And the coming from the superior vena cava into the tricuspid into the right ventricle. In a supracardiac type of TAPVC, because the oxygenated blood from the superior vena cava because of the connection to the vertical vein. That's a higher saturation. So that is streamed into the right ventricle, and the blood coming from the inferior vena cava through the ASD because of the valve. This is only one condition where you get the right ventricular saturation, maybe even higher than left ventricular saturation, because the left ventricle is getting blood from the IVC. So much so, this is one condition where the pulmonary artery saturation may be higher than the femoral artery saturation. The other thing you said it is cyanotic from the birth, but the cyanosis is not very severe, like pulmonary oligomelia or in the transposition, because there's a good flow. The cyanosis is sort of admixture. That means the mixing of the venous and the arterial blood, So they are not very cyanose, and the saturations, these chambers are equal. As Sri Krishna always asked you the previous, condition where the diastolic pressure in all the chambers of the heart are equal. Which condition is that? Where the diastolic pressure for the chambers are equal. One, saturation is equal. One, the diastolic pressures are equal. What condition is that where you get the diastolic pressures in all right atrium, left almost equal, maybe 5 millimeters deep. What condition is that? You have said this under. It's in constrictive pericarditis.
Constrictive pericarditis.
Pressure and the mean pressure of the pulmonary artery, they're all equal in such cases.
These are two. This is a standard Viva question.
Yes, sir.
Common pressure and common saturation. What are the books you read? Can you go back to your references? I think, the surgical aspect would be better seen in that,
So I'm taken from Mavrodis, surgical aspects.
no. Stark Dival. You should also read Richard Jonas's book, I think, for the
Yes.
further complications and other things.
Yeah.
Richard Jonas's comprehensive cardiac surgery has come. He's got a new book. It is available on your clinical key.
Okay, sir.
A very good book, actually. When I was at the start, he was a house surgeon in Melbourne. Then he went to Auckland. Then he went to Boston. He was in Boston Children's Book. We call him Rick Jonas. This book is very good. All the statistics, all the techniques, everything is given.
Correct. It's one of the very good book for congenital heart.
The Stark and J level is old, Not many people follow that.
Okay. Thank you. Thank you, sir.
Thank
you,
you
sir.
very much.